Just because your insurance company will pay for your colonoscopy doesn't mean you need one, and vice versa. If your insurance company refuses to pay for your colonoscopy, that doesn't mean you don't need one. I'm Dr. Robynne Chutkan, gastroenterologist, microbiome expert, and author, and I am here to help you find gut bliss. On today's show, I want to tell you about a conversation I had a couple weeks ago with a 30-year-old woman named Maria, who was having bright red blood in her stool on and off a couple times a week for the last 6 months. Now, when we talk about blood in the stool, why is it important to distinguish between bright red blood versus other types of blood? It's because the appearance of blood in the GI tract can tell us a lot about where the bleeding is coming from. Bright red blood suggests a bleeding source low down in the GI tract, like in the anus or the rectum. So the blood is coming out at the very bottom of your colon, and it's not mixed in with any stool, so it looks bright red, like regular blood, like when you get a cut. And sometimes that's exactly what the bleeding is from. It's from a fissure in the anal area, which is essentially a cut at the very end of your colon, right where the stool exits. If the bleeding is coming from a little higher up in your colon, it's usually mixed in with some of the stool that's sitting around, and it looks more maroon colored. Bleeding from your upper GI tract, from your stomach or small intestine, causes tarry black stool that we call melena. It's from the original Greek term melena, and that means black. Now, why is it black when you're bleeding from higher up in your GI tract? It's because enzymes that are up in the higher part of the intestine break down and digest the blood as it moves through your GI tract. And this gives it a black color and a strong, foul odor. And let me be clear, when I say strong and foul, I am not exaggerating. If I walk into the emergency room, I can tell right away if someone is having an upper gastrointestinal bleed because I can literally smell the melena before I even see it. And it does look exactly like wet, sticky tar. But Maria wasn't having melena. She was having small amounts of red blood in the toilet bowl and on the toilet paper. And it wasn't a ton of blood each time, but it was happening pretty frequently, about 2 or 3 times per week. She wasn't having any pain with bowel movements, which we usually see in people who are having anal fissures. They complain that it's painful when the stool comes out, and that was not her. Maria had seen a gastroenterologist, and he had done a rectal exam looking for things like fissures as well as hemorrhoids, and that is exactly what should be done if someone is complaining of bright red blood in their stool. But it's the next step in Maria's evaluation where things get a bit tricky. The Gut Bliss podcast is brought to you by Visbiome, my first and quite frankly, my only choice for a probiotic. Whether you're dealing with irritable bowel syndrome or just looking to restore your gut health, Visbiome can help. It's a medical food for the dietary management of IBS and gut inflammation. Backed by science and clinically vetted by thousands of my own patients. Find your gut bliss with Visbiome. Go to visbiome.com/gutbliss and use discount code GUTBLISS at checkout. Maria was not my patient. She was not under my care. She was a friend of a friend. And the friend had asked me if I would be willing to talk to her about what her gastroenterologist was recommending. And Maria's medical care was through an HMO, which stands for Health Maintenance Organization. The difference between an HMO and a typical fee-for-service, point-of-service, or preferred provider plan is that with an HMO, the HMO is both the insurer and the service provider. Whereas with those other types of plans, the insurance company is one entity and the provider is another completely separate entity, either a doctor in private practice, a hospital, a medical group, etc. Now, I want to be crystal clear on this next point. HMOs can and do provide excellent medical care. But one thing to consider is that with this model, the fewer procedures an HMO does, the more money they save. So on the one hand, that's good because you're less likely to get an unnecessary procedure, which is fantastic. But on the other hand, that can sometimes make it a little more challenging to get a procedure if there's not a very clear indication for it. In a fee-for-service system where healthcare providers are paid for each service they perform, the more procedures they do, the more money they make. So that's not ideal either, because you can end up with the opposite problem, an unnecessary procedure that you don't really need. And I got to tell you, that happens pretty commonly in our medical system, where if the insurance company is willing to pay for a procedure, then the provider will sometimes go ahead and do it, even if you don't really need it. The 6 most common surgeries that are done in the US that are frequently not medically necessary include pacemakers, cardiac stents, back surgery, especially spinal fusion, hysterectomy, knee and hip replacements, and C-sections. And these are often situations where there is actually a less invasive and less costly option, but the doctor or medical group or hospital chooses the more invasive, more expensive surgical option because, well, they're going to make more money. And I'm not suggesting that, doctors are doing unnecessary surgeries, but I'm saying that there's a lot of gray zone and that there are other factors that go into the decision-making besides just the clear medical indication. Now, in a fee-for-service plan, there are still checks and balances because the insurer has to approve the procedure, usually ahead of time, and the procedure has to fall within the guidelines of accepted practice. So, for example, with colonoscopy, there are specific indications like a change in bowel habits, unexplained anemia, history of polyps, screening for colon cancer if you're 45 or older. These are all indications for a colonoscopy that an insurance company will approve. But here's the thing. Just because your insurance company will cover the cost of your colonoscopy doesn't necessarily mean you need one, and vice versa. If your insurance company is refusing to cover the cost of your colonoscopy, that doesn't necessarily mean you don't need the colonoscopy. So what we have here is competing financial interests. And, you need to be aware of some of these economic realities and how they impact the care you're receiving. Ideally, doctors and healthcare systems should be making these decisions based on what is in your best interest, in the best interest of your health. And that is usually the case, but that's not the only criteria that they're using. And that's exactly the predicament Maria found herself in. The doctor had told her that because she was young, and she didn't have a family history of colon cancer or other worrisome symptoms, what we call alarm symptoms, like abdominal pain, unexplained weight loss, anemia, a change in her bowel habits. She didn't have any of that going on, and in his opinion, she did not need a colonoscopy. And according to guidelines from organizations like the American Society for Gastrointestinal Endoscopy, the ASGE, an organization I used to be on the board of, according to their guidelines, that is correct. And I know a thing or two about those guidelines because I was on the Standards of Practice Committee of the ASGE that helped to create them. And those guidelines say that if somebody is having intermittent rectal bleeding, like Maria was having, and they're less than 40 years old, like Maria was, and there are no alarm symptoms or risk factors, which she was not having, then they don't need a colonoscopy. But they should get a flexible sigmoidoscopy, which is sort of like a third of a colonoscopy. It's generally done without anesthesia, and it just looks at the bottom third of the colon. And the prep is not as intense as cleaning out the whole colon for a colonoscopy. So the goal with a sigmoidoscopy is to exclude things like hemorrhoids or fissure or inflammation in the rectum, things that you can see easily in that bottom third of your colon. But the guidelines go on to say that if the sigmoidoscopy is negative, they should then have a colonoscopy. Now, the reality is we can't do a sigmoidoscopy or a colonoscopy in every young person with rectal bleeding, nor do we need to, because the majority of those people will not have anything worrisome going on in their colon, and they don't need a colonoscopy. When I see a patient with rectal bleeding, I ask myself 2 questions. Number 1, what is the most likely diagnosis? And number 2, what is the most lethal diagnosis? Unfortunately, the answers to those two questions are usually two different answers. In the case of rectal bleeding, the most likely diagnosis is hemorrhoids or a fissure, but the most lethal diagnosis is colon cancer. So statistically speaking, Maria was much more likely to have hemorrhoids than colon cancer. But I want you to be aware that in the last 2 decades, rates of colon cancer have increased dramatically in young people. 500% increase in colon cancer in children ages 10 to 14. This is crazy. I never knew you could have colon cancer in children until the last decade or so. We're seeing a 333% increase in colon cancer in teenagers and a 185% increase in young adults. And there are lots of reasons behind this increase, this dramatic increase in colon cancer in young people. More processed food, less high-fiber fruits and vegetables, less exercise are 3 of the sort of big factors, but there are lots of complicated reasons. Colon cancer is now the leading cause of cancer deaths in men under 50 and the second leading cause of cancer deaths in women under 50. So while the guidelines say patients under 40 with intermittent rectal bleeding and no risk factors can have a sigmoidoscopy first and then a colonoscopy if that's negative, Maria's gastroenterologist was telling her she didn't need either, and she was worried. I spoke with Maria, and I recommended that she document her concerns on the patient portal. Not in a threatening way, but just in a sort of more official way, so that there was an actual record of it as opposed to just a verbal conversation. In a situation like this, you want to make sure your doctor has a complete understanding of your symptoms. And sometimes that's difficult to accomplish in a short office visit. It may just be, 5 or 10 minutes. So the best way to do that is to write something out and send it to them on the patient portal or in an email if that's available in the practice. And that can help you organize your thoughts about what's going on and present them in a clear and compelling manner. And just as importantly, it creates documentation that you have these concerns and they've been communicated to your healthcare provider. And this is not meant to be done in a threatening manner at all. This is not a, give me my colonoscopy or you're in big trouble. But it does create an opportunity for the physician to take a look at the situation again, to sort of review it, and maybe to reconsider their recommendation. And the reality is, yes, it does add a little bit of pressure to make sure that they're confident about that recommendation. So Maria did send that message on the portal. She wrote a very polite note, very well written, that said that she was really concerned about the bleeding because it had been going on for really a little over 6 months, and it was happening almost every other day. And she finally did get her colonoscopy. And it showed, drumroll, the most likely diagnosis. She had some internal hemorrhoids that the gastroenterologist had not seen on his rectal exam, and that was a cause of her bleeding. But the story does not end there. Her colonoscopy also showed a large polyp halfway up her colon. Now, this was beyond the reach of a sigmoidoscopy, so this would not have shown up on a sigmoidoscopy. And that polyp was completely asymptomatic. That didn't have anything to do with her bleeding. It was what we call an incidental finding. But it was a kind of precancerous polyp called an adenoma with a risk of turning into colon cancer over the next 10 years. Now, in 10 years, Maria would only be 40, so she still would not be at the age where we recommend a screening colonoscopy for colon cancer, which is age 45. So it really was luck that she had the blood in her stool from the hemorrhoids that led to the colonoscopy, that discovered the precancerous polyp that was removed. And because of the large size of the polyp, she's now on a schedule where she gets regular colonoscopy to check for more polyps. So let me leave you with 3 takeaways about navigating the medical system to get the care you need. Number 1, be familiar with the guidelines. What is a standard of care for the symptom you're experiencing? These are published by professional organizations within that specialty, and they're available to the public. Number 2, even if what your physician is recommending is within the standard of care, if you feel like you need something above and beyond that, in addition to having a conversation with your doctor, I recommend that you also document your concerns through the patient portal or in an email. And number 3, there's a fine line between a gut feeling that something worrisome may be going on or a feeling based on actual symptoms and irrational fear or paranoia. Make sure you are basing your concerns on the former, a gut feeling or concern about actual symptoms, and not the latter, irrational fear or paranoia. Having a conversation with someone who's well-informed, could be a friend of a friend who's a gastroenterologist, or sometimes even a formal second opinion with a different doctor can help you figure that out. So that's it for this episode of the Gut Bliss podcast on competing interests in healthcare and getting satisfaction when it comes to your care. Coming up next week on the Gut Bliss podcast, gluten face, real or imagined? Go to gutbliss.com for my free 7-day microbiome reboot course. If you like what you're hearing, drop a review and hit that subscribe button. And remember, dirt, sweat, vegetables, the best prescription for a healthy gut.
The information presented in this show is not meant to be medical advice. Consult your doctor before making any decisions about your health. The patients discussed are real people, but names and identifying features have been changed to protect their privacy.